All right, thank you. You can see my position. Debating with Dr. Sito is like debating with Dr. Kern, but I'll give it a shot. So I do not have any disclosures. I'd like to clarify something. The question really is not whether FFR is a gold standard, but rather what all is it a gold standard for. Adenosine FFR remains the gold standard because it has superior diagnostic performance versus any other invasive modality. It's been validated against multiple established standards. It's easily and universally available. It's highly reproducible. It's well tolerated as opposed to what some may have you believe. It's clinically effective both diagnostically and prognostically. It's highly cost effective, and it has established legacy for over 25 years. So Dr. Sito already went over this, but ultimately, when we're talking about physiological evaluation, it's the net blood flow that reaches the myocardium that determines the functional state of the patient. And when this maximal flow is compromised, ischemia and symptoms happen. So fundamentally, it should then be the maximal blood flow that should be studied to establish physiological significance. Going back to some physics basics, flow across a tube or a vessel is determined by the delta P, or the pressure at the start or the end of the vessel, and is inversely related to resistance. So if somehow you could get rid of resistance or keep it minimal or constant, then flow should be directly proportional to pressure, which is really the basis for FFR measurement. So FFR, we assume the resistance is going to be minimal or constant, and the venous pressure is the same at rest versus with adenosine infusion, and you get a simple measure. So it's really the ratio of maximal flow in a stenotic artery compared to if the artery were normal, or in other words, to what extent flow can be improved if that stenosis is gotten rid of. And understand that when we do an angiogram, we're only looking at 5% of the coronary tree. 95% of it is microvascular. So going back to a study that's almost 23 years old, the initial validation study, FFR, was validated against exercise stress test, thallium, and stress echo. The specificity was 100%, which meant that if the FFR is less than 0.75, you almost always have ischemia. And if you increase that threshold to 0.80 and above, you almost never have ischemia. And we have prognostic power that's been demonstrated in multiple randomized studies. Defer 15-year results were published about 5 years ago. And if you defer based on a non-ischemic FFR, the risk of a myocardial infarction is extremely, extremely low. FAME trials showed at 1 and 2 years that an FFR-guided strategy was superior to angiography alone. And at 5 years, although the P was no longer significant, numerically, patients who had an FFR-guided strategy did much better. Then FAME2 tried to answer a slightly different question, which is the main bone of contention between non-invasive and invasive cardiologists, i.e., if you have ischemia, do you treat that with medical therapy or PCI? And FAME2 showed us that up to 5 years, if you did PCI for ischemic lesions, these patients did much better. And this was not only based on urgent revascularization, but the difference is almost statistically significant for new myocardial infarction. And something that the FAME2 taught us is that once you do PCI for ischemic lesions, you literally change the natural history of disease such that patients who get PCI for ischemic lesions, their outcomes parallel that of non-ischemic lesions. So this is about the only study that has demonstrated that you change the natural history of disease after intervening on ischemic lesions. Then pooled data from 3 randomized trials looking at the same question demonstrated the same thing, that if you do FFR-guided PCI on ischemic lesions, that is better in terms of net events compared to medical therapy alone. FFR is also a gold standard for optimal clinical decision-making. In the cath lab, multiple studies have been published. I'll share 2 with you. Large multi-center French registry, 1,000 patients, FFR changed revascularization strategy in 43% of patients, and you can see this can have huge clinical and cost implications. Patients who were referred to CABG, less than half required CABG. Patients who were referred to PCI, less than half ended up getting a PCI, and clinical outcomes did not differ between those who were reclassified versus non-reclassified. Similar trends have been shown by other groups. A reclassification rate has been anywhere between 25 to 40%. It is highly cost-effective, as demonstrated by the FAME-1 investigators. And in FAME-2, the clinical question was different, but upfront, obviously, if you do PCI, the cost difference is $4,500 versus $10,000, but at 3 years, there's a late catch-up phenomenon because of readmissions for MI and repeat or urgent revascularization in the medical therapy arm. FFR is highly reproducible. There have been multiple studies. I'll share one by Dr. Johnson. Here they compared adenosine FFR, resting PDPA, and IFR, and you can see the scatter as demonstrated by the standard deviation is really low for FFR. There's a spread for PDPA and IFR. So if you look at this diagnostic accuracy pyramid, really angiography is 65% accurate, PDPA, as Dr. Cito alluded to, these are about 80-85% accurate. Contrast FFR is 85%, and FFR is close to 95% accurate. And FFR is also being used as a standard gold reference for newer non-invasive modalities. 23 studies with 4,000 patients, 5,400 vessels, looking at 6 different modalities, showed that contrast MRI or adenosine MRI had the highest diagnostic accuracy compared to all other modalities using FFR as a gold standard. And we've also learned that post-intervention FFR is an arbiter of physiological successful revascularization and should be used as an endpoint. So in conclusion then, FFR is the gold standard, remains the gold standard for evaluating hemodynamic significance of epicardial stenosis, for guiding revascularization, for invasive risk stratification, for cost-effective clinical decision-making, and establishing a physiological successful revascularization. So I agree with Dr. Cito. There are multiple NHPRs, and you can choose them, but adenosine FFR remains the gold standard. Thank you.